So sports radiology, we know that it had a rapid growth in the last 15 years, basically because of the great advances in ultrasound and MRI. And we know that football medicine, the services are provided at many sports events and venues, even away from traditional uh, hospital and clinic setting. We know there are two levels for in healthcare for these players. The first of them is the traditional medical or diagnostic facility, the hospital and the sports medicine institute. And also, it's growing in the last years. The radiologic evaluation on the performance environment away from the traditional hospital clinical setting, which we may call as a pitch side radiology. We have several professional football and American football and soccer teams that has imaging centers at their facility, either at the stadiums or at the training centers. And we can consider Aspetar as a pitch side radiology center as well, as we have the Aspire Academy and the Khalifa Stadium right beside us. The term polyclinic, which is a facility that provides immediate and necessary investigations to the and treatment also to the athletes, that is composed by sports medicine physicians and the whole sports medicine setting, which is included the radiologist. Here's an example of the polyclinic that we had for the Olympics in the Rio 2016. We can see here the apartments for the delegations, and right beside in the Olympic villa, we have the polyclinic here. So this is the setting we had in the Olympics. And inside this polyclinic, we had an imaging center as well, with MRIs and ultrasounds and X-rays, and the radiologists were active at this imaging center. There were two radiologists working daily from 7 a.m. to 11 p.m. discussing the cases with all the sports, the team physicians as well. So we know sports medicine by nature is multidisciplinary. The athlete management requires input from different specialties, and how the healthcare of the football player is approached and managed. Radiologist is an important part of this team, which is composed by physicians, therapists, trainers, and sports sciences in general. So the radiologist works in conjunction with the sports medicine physician and the whole team, and which are typically the primary healthcare provider for the athlete. Dr. Ian McCurdy, which was the president of the British Olympic medical session, he states that the sports physician's closest working relationship is typically with the radiologist. So our role as radiologists, as the imaging specialist in football medicine, is first to confirm the accurate diagnosis, of course, inform and help in the management in planning and making decisions in regards to return to play of the athlete, screening and pre-participation assessments as well, and technical assistance in certain procedures, as we'll see in the next 30 minutes. We know that diagnosis in sports imaging, the typical ones are acute, traumatic, and chronic overuse injuries. There is a high demand for accuracy and urgency in the diagnosis for managing these athletes. So the diagnostic process and decision making and return to play are basically the same, and imaging support is very important in this setting. And we also are available to do the image guided injections, as we'll see later. So the first lesson I would take from the radiology side is that the elite football player is more involved in the management of their injury when compared to the normal patients. Imaging also, we see in our experience that may have a very important impact on players' confidence. Either a positive impact, a minor finding that may not have a effect on physical performance, can have a negative impact on his psychological state, or a negative scan that can reinforce the player's confidence in their ability to perform the best. And the accurate diagnosis is required to appropriate treatment. We have to take in mind that imaging is complementary to clinical examination and history. So in that reason, we have to know the clinical information. There are some studies showing this, that the effect of clinical information on the final radiology report, and it has been shown there is evidence that with clinical information, about 83% of the reports become more accurate. So it is the clinical information communicated to the radiologist and definitely has a positive impact on the final radiology result. And that reason, there is improvement of the entire decision-making process. So it's very important that the clinical information gets to the radiologist in order to improve the entire decision-making process. Another lesson, every imaging method has advantages and limitations. We have to know what we're looking for to choose the right method, okay? And in football injuries, the football injuries are more common on lower extremities. Hamstrings, myotendinous tears are the most common injuries in football, up to 37% of injuries, almost 40% of injuries. Here's an example of a biceps femoris musculotendinous, proximal musculotendinous junction tear, comparing to the other side, the other normal biceps femoris tendon. Regarding the muscle injuries, we can have three locations. So we can have a myofascial at the peripheral part of the muscle, close to the fascia, the myotendinous junction, which is the muscle substance without affecting the connective tissue, the intramuscular tendon, and the intratendinous tear. The intratendinous tear affects the intramuscular tendon, the connective tissue, and it is known that it has worse prognosis in terms of recovery time, up to three times more requirement of recovery time in these patients when the intratendinous tear is present. So imaging is important to make this diagnosis. And here's an example of MRI. Here's a tear of the intramuscular tendon of the rectus femoris. You can see here the tendon normal, and here we can see the tear within this tendon. Another lesson we take from radiology is that muscle injuries, one question that is always asked for us, what is better for muscle injuries? Is it ultrasound? Is it MRI? We have to take in consideration some aspects. Ultrasound has a higher spatial resolution compared to MRI. However, MRI has a higher contrast resolution. Ultrasound has low cost, and for that reason is more accessible. It's a fast examination. It allows dynamic evaluation. However, it is operator dependent. It needs a training curve. And MRI has really high multiplanar spatial resolution, and it can evaluate soft tissue and bone at the same time. So answering the question, from our experience, and there is evidence for this, MRI can be reserved in case of muscle injuries for high performance athletes because of financial and logistic reasons. For potential surgical indications, for example, a complete tendon tear to stage this tear, and in case of a surgery. For chronic pain, in terms of differential diagnosis, MRI is better than ultrasound in that case, and also to overcome ultrasound limitation, which means muscles that are more proximal and deep located, for example, for the adductors. Here's MRI of the right thigh. We can see here the rectus femoris. Here with the black arrow, we have the central intramuscular tendon. There is no tear. And there is a tear at the musculotendinous junction here with this white arrow. Let's compare this with the ultrasound done in the same patient. So we can see basically the same thing. We can see the central tendon with the black arrow here. We can see the tear, the musculotendinous tear. There's some heterogeneity in the other side surrounding the intramuscular tendon, but the intramuscular tendon is normal. So this is a static examination. On ultrasound, we can do dynamic evaluation. We ask the patient to contract or extend or flex the limb. And in this case, we can see with contraction, the tear that we saw previously, and it was correlated with MRI, we can see it bigger. And also there's another tear on the other side that we didn't see on MRI. So dynamic evaluation is a powerful tool on ultrasound that we use for muscle injuries. Another lesson, muscle injury classification systems can be confusing. There are several classification systems for muscle injuries. The classic 1, 2, 3. There are the modified that was described initially for ultrasound, and then it was described for MRI. Then there was the Munich consensus and the British Athletic muscle injury and classification system. So depending if you look at this table, depending what you're talking about, for example, the grade 3 on the classic 1, 2, 3 classification is a complete tear. However, on the Munich and the British, the grade 3 is a partial high-grade injury. So we have to know, we have to speak the same language, the radiologist and either the physician, the therapist, or the sports science, to avoid this confoundings. So this patient here, we can see here the biceps femoris and the conjoint tendon. There is a tear here at the proximal conjoint tendon of the biceps on the right side on MRI. So we call this, according to the British Athletics classification, the length, the fact that it affects the intramuscular tendon, a grade 3C, according to British Athletics. The sports physician called me, why did you call it a grade 3 if it's not complete? And then we replied it's a grade 3C according to British Athletics and not the classic 1, 2, 3. The bottom line is we have to speak the same language. We have to be sure that everyone is aware of the classification system that we're using. Otherwise, we just have to make a descriptive report. Another lesson, what about persistent edema on MRI? We know that the persistence of edema-like signal on MRI can go on for about 6 months after the initial muscle injury. And it does not provide, there is evidence that show that it does not provide clinical value in the absence of any symptoms for the patient. Okay, so another question is the persistent edema on MRI, does it implies a higher risk of recurrence? There's no data regarding recurrence rates based on MRI. What about prognosis and return to play? So the usage of MRI for prognosis and to predict return to play is controversial. However, there is evidence if we have a negative MRI in a symptomatic patient, this is a good prognostic factor. And return to play time is about 7 to 10 days. Another evidence that's well established in the literature is about the affection of the connective tissue, the intramuscular tendon. When it is affected, as seen on MRI or ultrasound, it has a worse prognosis in terms of return to play. Okay, so now let's talk a little bit about growing pain, imaging growing pain. So I really like this classification done in the Doha Agreement meeting and published in the British Journal of Sports Medicine in 2015. And we know that growing pain is really common in football, up to 14% of the injuries. And we have 4 types of injuries. We have the most common one is the adductor-related growing pain, which is the most common cause of growing pain. And basically, we're going to see on MRI abnormalities related to the rectus femoris and adductor aponeurosis and tendons, especially the adductor longus. So MRI and more MRI, mostly MRI, is really sensitive for these tears. Ultrasound has a lesser sensitivity because it's a deep located muscle and a proximal muscle. So the best examination for evaluation of the adductor related growing pain is MRI. However, ultrasound can be useful depending on the patient we're evaluating. It can show the complete tear, as we can see here, a complete tear of the adductor longus, the retraction gap related to the origin at the pubic bone. And also it can show, depending on the patient, ultrasound can show adductor longus tendinopathy with partial ruptures right at the origin at the pubic bone. So ultrasound, although it is less sensitive than MRI, it is useful also for evaluation. Another type of growing pain is a pubic growing pain, which has very close relationship with the adductor tendons injuries. So basically, we're going to see pubic symphysis abnormalities, especially edema, as we can see here in this MRI, osteophytes, cysts, and usually, as we can see here on this image, related to adductor tear, on this case with the left adductor longus origin. Another cause of growing pain is the inguinal. So ultrasound is considered the best modality. Here we have an ultrasound showing a inguinal hernia here, a dynamic evaluation by ultrasound. However, MRI can also detect inguinal hernias, specifically when you use dynamic MRI. So here we have an example of posterior wall weakness, inguinal canal posterior wall weakness bilaterally here. In this other case, we can see here a small sports hernia at the left side, so seen on this dynamic MRI. So the best examination is ultrasound. However, MRI with its dynamic properties can also evaluate these inguinal types of growing pain. So another lesson we take from the radiology side is that growing pain imaging evaluation should assess all 4 types of causes, and this is possible with ultrasound and with MRI as well. So let's go to the knee injuries. The knee is frequently injured in football, also up to 14% of the cases, and MRI is the imaging modality of choice. Here in this patient, we have a knee injury, and we see here the classic bone marrow edema, the anterolateral femoral condyle, the posterior tibial bone edema, which is related to the pivot shift rotatory instability injury. And this was demonstrated recently in a work published here at Aspetar, that these MRI bone bruises correlates with the video analysis of the injury in ACL tears for the athletes. And here, these are indirect signs of an ACL tear. So here's the ACL tear for this patient. Just to remember the normal aspect of the ACL here and the torn patient, just to review why this ACL is torn on MRI. Also, meniscal injuries, MRI is very sensitive, up to 95% of accuracy for meniscal injuries. So in this case here in the left, we have a meniscal tear. You see that the high signal and the posterior horn of the meniscus extends to the inferior articular surface. So this is a real tear. On contrary, here on the right image, we can see that this high intensity linear signal at the posterior horn of the meniscus does not extend to the articular surface. So this is not called a tear. We compare this with arthro CT. We injected contrast in the articulation on the joint, and we can see that the contrast does not extend to the tear. So on arthroscopy, the orthopedic surgeon is not going to see this kind of injury. So we prefer to call this as a mucoid degeneration that on arthroscopy will not be seen. So it's very important to make this distinction. MCL tears are also common in football. We have three grades of injury. The grade 1, when on MRI, we can see this edema surrounding the ligament. On grade 2, there is edema inside the ligament. However, the continuity is preserved. In grade 3, a complete injury, we can see a detachment of the distal aspect of the ligament here from the tibial insertion, and you can see the ligament is lax and non-continuous here. Another lesson we take from our side regarding the knee injuries, that typical injuries are misleading. We have to be very cautious with these kinds of injuries. So this player had an injury here at this time. The meniscus, there was a suspicion of a meniscal injury. We can see here the meniscus itself, it has normal aspect, the normal triangular and hyposignal, the black signal, which is normal for this meniscus. However, if we look closely here, compared to an MRI done 2 months before for another reason, we can see posteriorly, we can see the popliteal fascicles posteriorly to the posterior horn of this lateral meniscus. And if we look at the MRI done now at the injury, we can see that there is effacement of these fascicles. They are blurred, they are thickened, they have increased signal, which is consistent with a popliteal meniscal injury. And 2 weeks after this MRI, the patient had a dislocated meniscal fragment, a bucket handle tear related to this popliteal meniscal fascicle tear. So if we this is a very uncommon type of injury, but we have to be very cautious to look at these details. Although the meniscus is normal, the meniscal attachments are not normal and can lead to a very serious meniscal injury if not diagnosed in time. Another type of typical injury, we can see here the chondral erosion here at the posterior aspect of the lateral femoral condyle. However, if we take which is a grade 3 chondral injury, complete thickness, no marrow edema. If we look closely at this injury here, it has sharp margins, which if you look at a chronic chondral injury, does not have these sharp margins. Usually there are more rounded and irregular. So when we see these sharp margins, we have to make the diagnosis of an acute chondral injury. If this diagnosis, if we have this diagnosis in mind, we have to look for the displaced chondral fragment within the joint. Okay, so first look at the morphology of the chondral injury. If it is suggestive of an acute chondral injury, we have to look in the joint for the displaced chondral fragment, which is very difficult in sometimes. In this case specifically, we can see that the chondral fragment is here anteriorly to the anterior horn. So he was detached from the posterior aspect and went here to the anterior recess of the joint. So this is very important because this is a surgical treatment and very, although it's uncommon, it's a very important decision we have to make. And here's a closer look of this displaced meniscal chondral fragment here. Let's go to the ankle. The ankle, we can have ankle sprains with acute inversion injuries, the most common injuries in the football player, Achilles tendon disorders, and ankle impingement. Depending on the clinical suspicion, one or other examination is more useful. Usually in ankle injuries, imaging is not required. We perform imaging when acute injuries that are difficult to define clinically and to grade them as well. And then players also who develop chronic sequelae. So these are the requirements for imaging assessment in ankle injuries in football players. We can have the ligament injuries. So MRI is very useful to see either the lateral or the medial ligament. So here we have an anterior talofibular ligament strain with a huge amount of edema surrounding. This was an acute injury, and also a deltoid, a medial ligament injury sprain here on MRI, also with surrounding soft tissue edema. We have to take in mind to know that abnormal ligaments on MRI can be stable, and on contrary, normal ligaments on MRI can be unstable. So imaging is complementary to clinical assessment. And also we know that torn anterior talofibular and calcaneofibular ligament are very common in football players and seen even in asymptomatic players. We can have syndesmotic injuries, as we can see here, a tear of the anterior tibiofibular ligament. These syndesmotic injuries can be associated with chondral injuries of the talar dome. So it's important when we have a syndesmotic injury, assess the talar dome to look for the chondral injuries associated. And here it's a complete chondral injury, a grade 4 chondral injury of the medial aspect of the talar dome with adjacent marrow edema and cystic changes. Also, ankle impingement syndromes are common in football players. It is a clinical diagnosis, and the role of MRI is to assess predisposing anatomic factors that can cause this specific impingement. This patient had a clinical history of posterior impingement, and on MRI we can see an os trigonum, a large os trigonum with degenerative changes with edema at the level of the synchondrosis. In this patient, MRI helped to make this diagnosis and to guide treatment. It was posteriorly performed an injection, a steroid injection of this os trigonum surrounding here the os trigonum and the synchondrosis in order to treat this posterior impingement. So here imaging helped diagnosis and treatment as well. In Achilles tendinopathy, which is a chronic overuse injury in the football players, we have seen less Achilles tendinopathy because of a better understanding of the injury biomechanics and proper adaptation in the training for the athletes. Ultrasound is an excellent method to assess the Achilles tendon. We can see here tendinopathy with the ultrasound. And we're going to talk about image-guided injections, either orthobiologic biologics, either for steroids. We can do it by several methods. We can do it guided by fluoroscopy, X-rays. We can do it guided by ultrasound. We can do it guided even by CT. Recently, even MRI is used to guide injections, although it's not widely available. Fluoroscopy is basically used for injection in the joints and the spine. CT also joints and spine, and ultrasound basically joints. So ultrasound guided injections are widely used. They can be used even pitch side in the training center, and it's done by not only by radiologists. Several physicians can perform image-guided ultrasound. I think the question is why to use imaging to guide in injections. Here's CT. We can use it basically. The greater indication is to spine injections. And here's an example of an injection done at our service. So here we can see the needle for fascia cruris injury and going to the thickened fascia cruris. And here's the injection with the PRP concentrate surrounding the Achilles tendon here. So why use imaging to guide an injection? There are several evidences that shows that using imaging, either ultrasound, fluoroscopy, or CT, is more precise in terms of the position of either the orthobiologics or the steroid or the anesthetic. It's less painful for the patient. It has better results, and it's lesser complication, and we have lesser complications. So I would change this question: why use imaging? Why not use imaging? I think would be the better question. Spinal injections, we know that low back pain is more prevalent in high performance athletes than in general population. And this leads to significant time missed from competitions. In spinal, for example, spinal discal hernias, we have the mechanical, two reasons for the pain: the mechanical phenomena, which is responsible for 40% of the pain when the disc compresses the nerve root. However, there is an inflammatory process that is responsible for up to 60% of the pain. So for this reason, the injections might be useful. Here's an example of an epidural injection guided by CT. We can see very well the dispersion of the medication on CT. It's really safe and precise in terms of injection. And here's an example of foraminal. You can see this foraminal injection, the medication extending close to the nerve and extending to the epidural region as well. Sacroiliac joint injections on CT are useful as well. The sacroiliac joint disorders are common in sports that require asymmetric loading. So it's common in football players because of kicking and swinging of the pelvis. And we can use the CT to guide this injection. We can see here the needle going to the right sacroiliac joint and the medication dispersed internally. So also precision and safeness in terms of injection. So in summary, imaging is an important complementary tool to football medicine. Hamstrings injuries are the most common injuries in football. MRI on muscle injuries are performed in high-performance athletes, players. When cases with ultrasound limitations in more proximal muscle groups and deep muscle groups for surgical planning and differential diagnosis. Remember that the classification systems, the whole team, the radiology and the entire team, physicians, therapists, sports science, should speak the same language to avoid misunderstandings. In terms of prognosis for most muscle injuries, MRI is important to evaluate the connective tissue involvement. In growing pain, imaging it's important that imaging assesses the 4 types of causes of growing pain. Be careful with the typical injuries in the knee, and also the clinical information. I think this is very important. The clinical information to the radiologist improves accuracy of the report. And to finalize, remember that image-guided injection is a powerful tool. So most of these topics were highlighted in this article performed in the Aspetar Sports Medicine Journal in 2021, this in the end of the year. So we have most of the images shown here, and the topics are in this article. If you're curious, you can assess. And I'll finalize my talk. I want to thank you. And you can contact me here at Aspetar and even on social media. And thank you.